My name is Tyler Nguyen, and my PICO question is, for adult patients undergoing surgery, how does implementation of ERAS protocol compared to standard bed rest affect quality of care within their recovery? This topic was interesting to me because while I was in clinicals at Sutter, they were just implementing this new policy, so I was pretty curious as to what it meant and why we were doing it. So what it is is a protocol that outlines interventions before, during, and after surgery, such as giving a clear ensure before surgery to ensure adequate nutrition, following specific fluid guidelines during surgery, and more. Specifically, I wanted to focus on the recovery period, which lists interventions such as early mobilization, removing drains as soon as possible, early feeding, and more. And you can see on the picture above. And so this is important because these interventions are supposedly supposed to lower and the length of stay. By lowering the length of stay, you are reducing the odds of mortality as reported by an article mentioned in my paper by Lingsma in 2018. My search was not too challenging as there were a lot of researchers asking the same question, since this is a relatively new protocol and hospital floors are still hesitant to implement this just based on resources and staffing concerns. And so more evidence is still needed to convince hospitals in different regions to whether or not to implement this. All of these articles that I researched were within 10 years, and they use different statistics to measure effectiveness through things such as patient evaluations, rates of complications, and length of stays based off of different procedures and different hospitals. What I found was that patients consistently rated floors with ERAS policy to be more effective in lowering anxiety, depression, and overall satisfaction, as reported by questionnaires and self-evaluations. I also found that ERAS policy often correlated with lower rates of complications as well as lower length of stays. In studies that followed patient outcomes after surgery on different floors with different procedures. A limitation in these studies were the lack of consistent variables, since the population in most articles needed to be sampled from different hospitals and floors. This was good in showing how generalizable these findings were, but it made it hard to compare these readings in the evaluations, since different hospitals may have different biases for patients, which interferes with the genuinity of the ratings. So overall, I would say the ERAS policy is more effective than the standard bed rest because the studies often show that ERAS was better at supporting the patients physiologically and psychologically compared to standard bed rest. I would also recommend hospitals implement this policy for floors that have patients recovering from surgery, if the hospitals have enough staff and resources to do so, since it is more taxing on the staff. Thank you for listening.